Usually when you picture a life-threatening medical emergency, say, a patient is in acute renal failure and their serum potassium is like spiking to dangerous levels.
Right.
You'd expect the intervention to be some highly specialized nephrology drug, right? But the protocol to save that patient's life actually relies on an asthma inhaler and a drug designed to manage blood sugar.
Yeah, it seems completely counterintuitive, especially if you strictly categorize drugs by, their target organs.
Exactly.
But when you strip away the organ systems and look purely at the cellular receptors and microscopic pathways, it makes perfect sense.
And that is exactly what we are doing today. If you're listening to this, you are likely staring down the barrel of the NAPLEX exam.
Right, yeah. The dreaded NAPLEX.
Right. We know the feeling. You're reviewing these massive, dense study sheets, trying to use rote memorization to lock in, hundreds of drug names, thresholds, clinical algorithms.
And it's overwhelming.
It is. But under the pressure of a board exam, memorized lists, they vanish.
They absolutely do.
Yeah.
Memorization is incredibly fragile. But understanding the mechanism, that's permanent.
Yeah.
When you understand the underlying pharmacokinetics and the specific receptor antagonism at play, you don't have to memorize a list. You can simply logic your way to the correct multiple choice answer.
So our mission for this deep dive today is to completely abandon that standard table of contents approach to studying.
Love it.
We're taking 3 topics from your materials that seem entirely unrelated: chronic kidney disease, nausea in pregnancy, and motion sickness.
Sounds like quite the mix.
Right. But we're going to look at them through a single lens, manipulating cellular receptors to solve unexpected problems.
Right.
We're going to explain the terminology like you're hearing it for the first time, build mental case studies, and explicitly link these drugs to other diseases like hypertension and diabetes, so they stick in your head for exam day.
And we are starting with the heaviest hitter on the board, which is chronic kidney disease, or CKD. As a future pharmacist, this is not a niche condition you'll see, like once a month. This affects more than 1 in 7 U.S. adults.
Wait, really? 1 in 7?
Yeah, 1 in 7. That is roughly 37 million people. You're going to be managing renal hemodynamics pretty much every single day of your career.
Wow. Okay, so let's build our first mental model for the exam. You have a patient profile. They have CKD, but they also have cardiovascular disease and type 2 diabetes.
Which is an incredibly common trifecta.
Right, and your treatment plan has to manage all 3 simultaneously. Now, the 2 metrics dictating your entire decision tree here are eGFR and albuminuria.
Yes.
So for someone just starting their review, break those down.
Sure, so think of GFR, the filtration rate, as the kidney's filtering speed limit.
Okay, speed limit.
Right. It's categorized from G1 all the way down to G5, where less than 15 is kidney failure.
Got it. And the albuminuria?
Albuminuria is the leakage. It's protein that absolutely shouldn't be slipping through the filter. And that's categorized from A1, which is normal, to A3, which is severely increased leakage.
Okay, that makes sense. So the foundational treatment for this patient, our baseline defense, is an ACE inhibitor or an ARB, up-titrated to the maximum tolerated dose.
Correct. Everyone gets that baseline defense.
But wait, let's stop and look at the mechanism here, because we categorize ACE inhibitors and ARBs as classic hypertension drugs.
We do, yeah.
They lower systemic blood pressure. So why are we relying on systemic blood pressure medications as the primary shield for the kidney's delicate filters?
It is all about the internal plumbing of the nephron. You have blood flowing into the glomerulus through the efferent arteriole and blood flowing out through the efferent arteriole.
Right.
Think of the glomerulus like a highly pressurized espresso machine.
Okay, I like that.
If the pressure inside the filter gets too high, the delicate membrane breaks down and grounds, or in this case albumin proteins, leak into your cup.
Oh, wow. That's a great visual.
Yeah, and normally angiotensin II constricts that exit valve, the efferent arteriole, which keeps the pressure inside the filter really high.
So by using an ACE inhibitor or an ARB, we're blocking that angiotensin II pathway.
Exactly. Blocking it dilates the efferent arteriole. It physically opens up the exit valve.
Ah, okay.
That reduces the pressure inside the kidney's filter, which stops the membrane from stretching and tearing, and that halts the protein leakage.
Okay, so we've opened the exit valve to relieve the pressure. That brings us to the next massive intervention on the exam blueprint: SGLT2 inhibitors.
Oh, these are game changers.
Yeah, specifically dapagliflozin and canagliflozin. We initiate these when the eGFR drops below 60, regardless of the albuminuria level. Or we initiate them based on specific protein leakage, right? Like a UACR greater than 30 for dapagliflozin or greater than 300 milligrams per day for canagliflozin.
And just keep in mind, for the exam, not all SGLT2 inhibitors carry this specific renal indication.
Really?
You really must stick to dapagliflozin and canagliflozin for these specific CKD scenarios.
Right, right. But here is the critical NAPLEX pearl where I think a lot of people trip up. Let's say you start a patient on an SGLT2 inhibitor because their eGFR is 55.
Okay.
A few weeks later, you check their labs, and their eGFR has dropped to 50. It has fallen below the initiation threshold.
Yeah, that happens a lot.
The instinctive reaction is to panic, right, to assume the drug is causing acute kidney injury and just stop the medication immediately. But the rule from the text is actually to continue the drug unless it isn't tolerated or they start dialysis.
Yep.
Why on earth are we ignoring a declining filtration rate?
Because that initial dip isn't a sign of failure. It's actually proof the drug is working.
Wait, really?
Yes. Let's go back to our espresso machine analogy. If ACE inhibitors open the exit valve, the efferent arterial SGLT2 inhibitors work on the inlet valve.
Okay.
By altering sodium delivery to the macula densa, SGLT2 inhibitors trigger the constriction of the afferent arterial.
So they're tightening the pipe leading into the filter?
Precisely. So if you tighten the pipe leading in, the overall flow rate, the GFR, is naturally going to drop a little bit initially.
Oh, because there's just less fluid entering the system.
Exactly. But that slight drop in flow means a massive drop in the destructive pressure hitting the filter. You are trading a small, temporary decrease in filtration speed for the long-term preservation of the nephron itself.
That makes so much sense.
You have to ride out that initial drop because that hemodynamic shift is exactly what protects the kidney from completely failing years down the line.
That is a phenomenal way to lock that into memory. ACE inhibitors open the exit, SGLT2s tighten the entrance, both drop the internal pressure.
Exactly.
But let's fast forward in our clinical scenario. Say the pressure was just too much, the nephrons have degraded, and we hit renal impairment.
Right.
The blueprint defines this as a serum creatinine greater than 1.2 milligrams per deciliter, or a creatinine clearance under 30 milliliters per minute. When the filter breaks down, we enter the hyperstates.
Yeah, this is where it gets dangerous. Toxic things build up and essential things stop being manufactured.
So the first major buildup is phosphorus, resulting in hyperphosphatemia.
Right, because the kidney can no longer excrete it. So phosphorus accumulates in the blood, which eventually pulls calcium out of the bones and literally calcifies the cardiovascular system.
Which is terrifying. So the treatment strategy is using phosphate binders, but the pharmacokinetic timing here is the entire ballgame, isn't it?
It really is.
You can't just take these whenever. They must be taken with the very first bite of food. I always picture phosphate binders as a bouncer at the club doors of your GI tract.
I love that. A bouncer.
Yeah, they literally have to be standing at the door right as the food enters to physically bind the phosphorus before it can get absorbed into the bloodstream.
Right.
If you take the binder an hour after the meal, I mean, the phosphorus is already inside the club causing trouble.
That is the exact mechanism. They form insoluble complexes in the gut. Now, for the exam, you need to navigate the three classes of these binders and understand why we choose one over the other.
Okay, break it down.
First, you have aluminum-based binders, like aluminum hydroxide brand names, Alternagel or Amphogel, dosed at 30 milliliters 3 times a day with meals.
But we don't like keeping patients on aluminum long-term, do we?
We don't know, because a failing kidney can't clear aluminum either, which leads to neurological and bone toxicity.
Yikes, okay.
So we often utilize calcium-based binders instead. That's calcium acetate, known as Foslo, dosed at 1,334 milligrams 3 times a day with meals, or calcium carbonate, which is TUMS, at 500 milligrams.
But wait, if they're already pulling calcium out of their bones because of the phosphorus, aren't we risking, like, hypercalcemia by giving them massive doses of calcium binders?
Exactly. That's the catch. If their calcium levels spike, you have to abandon the calcium binders and move to the third class, aluminum and calcium-free options. This is where you see lanthanum carbonate, brand name Fosrenol, at 500 milligrams, or Sevelamer, which is Renvela or Renagle, at 1,600 milligrams, and again, all taken 3 times a day with meals.
Okay, so that manages the toxic buildup. Let's talk about the essential things the kidney stops manufacturing. Vitamin D deficiency is a massive trap on the board exam.
Oh, a huge trap.
Right, because a healthy kidney utilizes an enzyme called 1-alpha hydroxylase to convert inactive vitamin D into its active form. But when the kidney fails, that enzyme basically disappears.
Which means if you give a CKD patient an inactive over-the-counter vitamin D supplement, it is completely useless.
Because their body has no physiological way to activate it.
Exactly.
So you have to know the specific nomenclature. You must give them the pre-activated form. You need to memorize calcitriol, brand name Rocaltrol, which is vitamin D3, as the active form.
Yep.
Conversely, ergocalciferol, brand name Drisdol, vitamin D2 is the inactive form. Do not pick ergocalciferol for a patient with end-stage renal disease.
That distinction will absolutely earn you points on the test.
Awesome. So let's move to the most critical, immediate threat in renal failure. Hyperkalemia. Excess potassium. This brings us back to the hook of the show.
Right, the emergency protocol.
The kidney is failing, potassium is spiking, the heart's resting membrane potential is becoming dangerously unstable, and a lethal arrhythmia is imminent.
It's a terrifying clinical scenario.
It is. And the protocol cocktail includes glucose, insulin, sodium bicarbonate, albuterol, furosemide, and kayexalate.
Quite the mix.
Let's break this down mechanistically, because administering an asthma medication for a kidney problem sounds insane until you look at the cellular receptors.
It all comes back to manipulating pathways.
Yeah.
Potassium is normally highly concentrated inside our cells, right? With very little in the blood serum.
Right.
When the kidneys fail, serum potassium rises rapidly. We don't have time to wait for a drug to slowly pull potassium out of the body through the GI tract. We have to clear it from the blood immediately to stabilize the cardiac tissue.
So we use insulin and high-dose albuterol.
Because both insulin receptors and beta-2 adrenergic receptors, which albuterol targets, are directly linked to the sodium-potassium ATPase pump on the cell membrane.
Oh, interesting.
Yeah, when you administer regular insulin intravenously and give high doses of nebulized albuterol, you hyperstimulate those pumps.
So they act like cellular vacuums.
Exactly. They act like cellular vacuums, rapidly pulling the dangerous potassium out of the bloodstream and shoving it back inside the cells where it can't affect the heart rhythm.
Wow. And obviously, if you give a massive IV push of insulin to someone who isn't actively hyperglycemic, you will cause fatal hypoglycemia.
Yes, which is bad.
Very bad. That is why the glucose is administered simultaneously, strictly to offset the insulin.
Spot on.
And what about the sodium bicarbonate?
It operates on a similar principle. By raising the serum pH, it causes an intracellular shift, exchanging hydrogen ions for potassium ions, further hiding the potassium inside the cells.
I love that concept. We aren't actually removing the potassium from the body yet. We're just hiding it inside the cells to stop the heart from failing.
Yeah.
It's a temporizing measure.
Exactly. It buys you time.
Once the riot is off the streets and hidden in the houses, then we bring in the buses to actually get them out of the city.
Great analogy.
That is where the furosemide, a loop diuretic, and the kayexalate come in to physically excrete the potassium through the urine and the gut.
It is a beautifully orchestrated sequence of receptor pharmacology.
It really is. Okay, let's completely shift our clinical focus. We've spent this time manipulating receptors in the renal and cardiovascular systems.
Right.
Let's look at what happens when we manipulate pathways in the central nervous system. Specifically, we're looking at nausea, starting with case scenario 2. A patient in her first trimester of pregnancy comes to the pharmacy experiencing severe hyperemesis.
Right, so managing pregnancy nausea requires a strict, tiered, step-up approach. You are navigating the chemoreceptor trigger zone in the brain, but you have the added complexity of avoiding teratogenic effects on the fetus.
So you start conservative.
Exactly. The baseline is natural remedies. The standard recommendation is ginger in tea form or cooked.
But I want to highlight a very specific parenthetical note in the clinical guidelines. It explicitly says no supplements for the ginger.
Yes, that's crucial.
Why make that distinction on an exam?
Because dietary supplements are not strictly regulated for concentration, purity, or active ingredient uniformity by the FDA.
Oh, right.
In a pregnant patient, a highly concentrated, unregulated ginger extract poses an unknown safety risk. You want the dietary form.
Okay, but when the tea inevitably fails, we have to climb the escalation ladder.
We do.
First-line pharmacotherapy is vitamin B6 pyridoxine at 25 milligrams every 8 hours, often combined with doxylamine to make the combination drug declages.
Yeah, very common.
But wait, doxylamine is an antihistamine. Why are we using an allergy medication to treat pregnancy nausea?
It goes back to receptor pathways again. The vestibular system and the vomiting center in the brain are rich in histamine 1 or H1 receptors. By antagonizing those H1 receptors, doxylamine effectively blocks the nausea signal from propagating. That is why other antihistamines like diphenhydramine and meclizine, known as Antivert or Dramamine, are also considered first-line agents.
Okay, so H1 receptor blockers are our safe first-line zone. If she is still refractory, we move to the second line. Dopamine antagonists.
Yes.
These target the D2 receptors in the chemoreceptor trigger zone. We are looking at prochlorperazine, which is compazine, and metoclopramide, which is Reglan.
But there's a massive exam detail to flag here regarding promethazine, brand name Phenergan.
Right. It is strictly marked as RX only.
It's a critical distinction. Promethazine has potent CNS depressant effects and carries severe box warnings regarding tissue necrosis if administered incorrectly via IV.
Wow, tissue necrosis.
Yeah, so for the purposes of a board exam, if you're looking at an over-the-counter recommendation scenario, promethazine is always the wrong answer.
Excellent point. Okay, if the dopamine antagonists fail, we reach the third line, serotonin antagonists, specifically blocking the 5-HT3 receptors with ondansetron or Zofran.
But while we are navigating this ladder, we absolutely must discuss the red flag in this section, corticosteroids. Medications like methylprednisolone or dexamethasone.
They are potent anti-inflammatories and they do have antiemetic properties, but the guidelines explicitly state they must be avoided in the first trimester.
Yes, there is clinical evidence linking first trimester systemic corticosteroid use to an increased risk of oral clefts in the fetus.
That's a huge red flag.
Absolutely. If you see a first trimester patient in a clinical vignette, you must cross corticosteroids off your differential immediately.
Got it. Okay, speaking of the vestibular system and navigating these antiemetic pathways, that brings us to our third and final clinical scenario.
Let's do it.
We're moving from hormonally triggered nausea to kinetically triggered nausea. Our patient is not pregnant. They're about to board a cruise ship and suffer from extreme motion sickness.
This is the classic application for the scopolamine 3-day patch, brand name Transderm Scope.
Let's look at the mechanism. Scopolamine is an anticholinergic. It targets the muscarinic receptors.
Specifically, it blocks the M1 muscarinic receptors in the smooth muscle and the central nervous system, which are heavily involved in the vestibular nausea pathways.
But for the exam, simply knowing the mechanism isn't enough, right?
Yeah.
You'll be tested on patient counseling and pharmacokinetics.
Oh, heavily tested on counseling.
The instructions for the scopolamine patch are incredibly rigid. You apply a 1.5 milligram patch behind the ear, but the timing is the clincher. It must be applied 4 to 6 hours prior to travel. You cannot just slap it on as the boat sounds its horn.
And there's a pharmacokinetic reason for that. Transdermal drug delivery requires time for the medication to penetrate the stratum corneum and reach therapeutic concentrations in the systemic circulation.
Makes sense.
The postauricular skin behind the ear is relatively thin, which aids absorption, but it still takes hours to reach the necessary central nervous system blockade.
Right.
Once applied, it provides a steady state of medication for 72 hours. Meaning the dosing frequency is strictly every 72 hours.
Now, what if the patient refuses a patch and wants an oral option? The clinical alternative brings us right back to our first-line pregnancy drugs, the antihistamines.
Yeah, because of the receptor cross-reactivity. First-generation antihistamines don't just block histamine. They have significant secondary anticholinergic properties.
Oh, so they mimic the muscarinic blockade of scopolamine.
Exactly. They hit the same pathways.
So we can use the oral antihistamines, but the pharmacokinetic timing changes drastically. Because they don't have to cross the transdermal barrier, they are taken 30 to 60 minutes prior to travel.
Correct. The oral bioavailability allows for a much faster onset of action.
Okay, just look at the mental map we just built by focusing on cellular pathways instead of just memorizing isolated lists.
It's so much more intuitive.
Right. We started with the physical hemodynamics of the kidney. We utilized blood pressure medications to dilate the exit valve and diabetes medications, the SGLT2 inhibitors, to constrict the inlet valve, perfectly balancing the pressure inside the nephron.
Then we managed the chemical fallout of a broken kidney. We used bouncers at the door to block phosphorus absorption in the gut. We supplied the pre-activated form of vitamin D because the kidney's enzyme factory shut down.
Yeah.
And we deployed a brilliant combination of insulin and asthma inhalers to hijack the cellular pumps, shoving deadly potassium out of the blood and into the cells to stabilize the heart.
Then we seamlessly transitioned to the central nervous system. We blocked H1 receptors with antihistamines to safely manage pregnancy nausea, escalated to blocking D2 and 5-HT3 receptors when necessary, and explicitly avoided corticosteroids to prevent teratogenic harm.
Right.
And finally, we blocked muscarinic receptors with a transdermal scopolamine patch to preemptively shut down the vestibular nausea of motion sickness.
When you look at the material this way, it isn't just a spreadsheet of random facts. It is a highly logical, interconnected system of pharmacological levers and pulleys.
It fundamentally changes how you approach a clinical vignette. So, as we wrap up this deep dive, we want to leave you with a broader concept to ponder.
Sure.
Throughout these different scenarios, we continually saw drugs crossing their traditional, historically defined boundaries. We used hypertension meds to save kidneys, asthma meds to treat electrolyte spikes, and allergy meds to settle stomachs.
Yeah, it's wild when you step back and look at it.
As you prepare to pass the NAPLEX and enter practice, consider this. Are we rapidly moving toward an era of medicine where we completely abandon the idea of categorizing drugs by the disease they were originally invented to treat?
That's a great question.
Will future generations of pharmacists organize their entire dispensaries not by organ systems, but purely by the microscopic cellular pathways and receptors those molecules unlock?
It is a fascinating evolution of the profession. We're really moving from treating the symptom to hacking the fundamental cellular code.
It definitely makes you wonder what invisible connections are sitting in the pharmacy right now, just waiting to be discovered. Trust your understanding of the mechanisms, rely on your mental hooks, and you're going to crush this exam. We'll catch you next time.